Let's wait for a minute because attendees are starting to show. There we go. All right, good morning, those that are joining us. We're waiting for a couple of minutes just to make sure that we start with a good, considerable group of people. All right, okay. Good morning. Thanks for joining us today for our webinar. You know me, my name is Carmen Boone, Education Coordinator from Oregon Pacific AHEC, and we're a hosted agency of Samaritan Lebanon Community Hospital. Our mission is to promote access to healthcare through community and educational partnership. And today I'll be your host and moderator. Let's go over some housekeeping items. On your panel, you will notice that we are muting all microphones. They'll remain muted until we need ask you questions or we need your participation, and you can unmute yourself as well. You will receive a copy of the slides after the webinar. Use the chat box for questions and comments at any time. And we can answer them or we can talk about your question depending on how the webinar is developing. We are recording this webinar and you can find it on our YouTube channel. And you can see the address right on your screen. Any questions, please email me. You'll see my email address there. Now, for those of you that are need for a certificate, you can get your contact hours or CME or CE credit logging into www.eats.com and entering today's activity code. Keep in mind that the code expires in 1 week. We will email you these instructions today as well. This presentation is jointly provided by Samaritan Health Services, Oregon AHEC, Oregon Health and Science University, and Oregon Pacific AHEC. And the presenters and the planners of this activity reported we have no conflicts of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. These are our great, awesome presenters, Christine Runyan, Ortina, and John Fleischman. One thing I'd like to indicate is that I will share with you the code to obtain your certificate at the end. And via email. Okay, so no worries about that. All right, so briefly, Dr. Ranian is a nationally recognized leader in collaborative care, which focuses on bringing accessible mental health care into medical settings, especially for underserved communities. And Joan, she was a former behavioral health clinical director for OHSU's Department of Family Medicine from 2014 to 2020, leading behavioral health services, primary care, based medication-assisted treatment for opioid use disorder, and trauma-informed care implementation. Now I'll leave you with Tina and Joan.
Thanks so much, Carmen. Good morning, everybody. Hopefully you had some caffeine or some water or some good breakfast, or maybe you're eating your breakfast while you're watching and listening. We're really going to dive into a lot about what we were talking about 2 weeks ago in our more didactic-y session. But we're really we're going to remind you a little bit about what we talked about, but we have 2 cases to talk through, and then hoping that we can open it up to talk through any cases or questions that came up last time and really get a sense of how you're grappling with how to apply trauma-informed practices in your practice. So what would help me is if you would put in the chat, just remind us what setting you're in and what kind of work you're doing, what role you are, what kind of professional you are, and what setting you're in. And that will help us kind of frame some of the work and the talking points that we have today. So I'm going to go ahead and share my screen and just go through a few slides. But if you have, Carmen, everyone can access the chat?
Yes, everybody can access the chat.
Okay. So if you want to just introduce yourself, let us know what your profession is and what practice setting you work in, that would be wonderful. So let me go ahead and share the screen. Do you want to say anything while we're kind of getting started?
Excuse me, sorry. I just want to echo good morning to everyone. It's so wonderful to start to see some familiar faces and familiar names as we work together over time, and just another shout out of gratitude for all the work you're doing during this really challenging time, and hopefully some of that work and compassion and care that you're giving to others is also circling back on yourself.
Thank you. So we're kind of diving into the what and the how of trauma-informed care. And here is this is our series. We're in kind of smack dab in the middle. In 2 weeks, we'll be talking about self-compassion, and then we'll have a practice lab on that as well. So our disclosure is that we provide mental health services and well-being consultation and well-being services to individuals and organizations. And these are the learning objectives for today, really about naming and being able to implement some actionable practices. And so and there's a lot of engagement in this session. So I'm hoping we can, I know it's early, but I'm hoping we can get some good conversation going. So I want you to think about your clinical practice over the last 2 or 3 weeks. And I want you to think about if there was an interaction with a patient or a client that really, that was really challenging and really difficult. And if there isn't one in the last few weeks, maybe just thinking about what are the most challenging behaviors that show up in your patients. What are the most challenging for you to kind of tolerate and manage and sit with or interact with? And I want you, we can't turn to our neighbor, so we're just gonna be in a big group, and I'm gonna take the slides down for a second. And I want you to just if you would share what that is, we're going to take some notes, and then we're going to come back to this in a few minutes. And so we're going to come back to this. So I'm just going to stop sharing for a second and see if we can, if a few people would share about kind of what are the most challenging, someone's saying they're having a hard time hearing me. Is it better? So what are the most challenging behaviors that show up for you in your practice? Like, what, excuse me, what are the most, what are the patients that are just hard? What are they coming, how are they presenting? Mental challenges. So can you say more about that, Roma? What does that mean to you? I'm curious. Manic and explosive, sure. Yeah. Carmen, can they unmute themselves? Do they have that capability? Aggressive. Yeah. Celia saying homeless, folks who have no income or have some learned hopelessness and sometimes some learned helplessness, that they haven't developed a sense of self-efficacy. And the way they get their needs met is really through accessing services and have a hard time kind of initiating for themselves. Uncomfortable with support. So I think we often care for people that we will say they'll seek help, but then they kind of push it away at the same time. You can surely talk about that. Yeah. Mental health. Yeah. Fresh in recovery from addiction. Yeah, Regina's sharing about a patient who she had recently who had a history of substance use disorder, and at discharge was very angry and name calling and yelling and not cooperative during the discharge process. Yeah. Yeah, Esther, you shared when someone does not accept a polite no. So you have to so it's setting boundaries, that having a polite boundary setting of no. And so you have to reiterate it more. That's one option, to state it more strongly than you really want to. It pushes you, maybe. It triggers you to need to set that boundary stronger. Bordering on being a type of person you don't want to be. It pulls you into a place that doesn't align so much with your values. I think that's what happens in those moments. And then you kind of walk away and you're like, that's not who I am. That's not how I want to interact with people. But how did that happen? How did I get pulled into that? What happened in that moment? Others, did I miss any of them? Yeah, I think just people thinking, Dora, your comment about patients who are depressed and can be very voicing suicidal ideation or have an active plan. And then it seems like there's not a desire to make movement or get better, or there's not that inertia to make change. And sometimes it can feel like we are working harder than our patients. That's always an interesting moment when you check in with yourself about, what is that about? It seems like I am working, doing more invested, which doesn't always mean that's a bad thing. Sometimes people need to see that we are going to invest in them for them to be able to invest in the process as well. So these are great. Thank you so much for sharing.
Can I add one comment, a reflection inherent in the question that you asked and in the responses in the chat? There was this distinction between the people and the behavior. And I heard that in your question, and I read that in the chat. And I think it's such a valuable, as a caregiver, it's such a valuable distinction that we watch our own labeling of people and we stay confined to the behaviors that that are surfacing, and not make that a reflection of all of who they are, or we don't decontextualize it from their experience. So somebody is not ungrateful, they are showing hesitancy, their behavior is hesitant to accept help. And I really appreciate your framing of the question in that way, and everybody's engagement in the chat really embodied that distinction, which I think is very trauma informed.
Yes, I very much appreciated that. So we presented about trauma-informed care last time, and we looked at the 6 tenets, kind of the principles and the R's from SAMHSA. And I'm curious if y'all have some pen and paper, that would be great. But you don't have to. If you want to just take a moment and maybe take a few notes or grapple in your head with, what is trauma-informed care to you? How do you articulate it? How do you wrap your head around this concept? And how would you explain it to a colleague or a friend? And what does it mean to you? I think that there's the definition from SAMHSA that is a little, we use it in research, and we use it in kind of our scientific clinical work. And it is trying to embody the more human side of caring for humans. But I'm curious about, how do you describe trauma-informed care? What does it mean to you? And maybe we can just have some of that. You want to put it in the chat or unmute and take a stab. There's no right or wrong here. I think what I want you to do is start to, how do you understand it, and how do you apply, again, it's a lens or a concept to your work. Does anyone want to take a stab at it? Well, we can all kind of help each other. So what would it mean if you said, yeah, I'm learning how to practice trauma-informed care, or my practice, I'm learning how to implement trauma-informed care in my practice? What would I see, or what would I hear, or what would you be doing? Anyone want to take a stab at that? So yeah, Esther, 2 aspects are removing the drama and replacing it with the cause to affect. So I think thinking about, what does that mean, removing the drama? Is that the drama that's happening? I think about drama as like high emotionality, right? So maybe part of what you're saying is addressing that emotionality, acknowledging it's there, recognizing it, and then kind of thinking about what the cause is, and what the cause is for the affect, and having to think through, okay, so how do I actually help regulate in that moment? Illness and injury manifest differently when there's a trauma experience in the past or present. Yeah, it can. I think that's one of the pieces that is the idea of trauma-informed care, that our histories can impact how we're relating to and showing up in the present moment. And we don't know if someone's had a history of trauma that is impacting their present moment experience. So we use the universal precaution approach. And that's the whole idea of the universal precaution approach, because that is essentially a way that we don't have to ask or try to assume if someone has had a history of trauma, because you can't see that on the outside. It's not something you can see. So that, yeah, I like that comment. Thank you. You know, feel free to jump in here too.
Hello?
Hi, Roma, did you want to make a comment?
Oh, you know what? I just wanted to make sure my speaker was working. That's all.
We hear you loud and clear.
Okay, good.
Trauma-informed care is having in mind that this person may have had trauma and then looking for better words, understanding this played a role, and then moving forward to help patient out. I love that. That is actually like the 4 R's right in that little chunk without even using any of the R words. But that is exactly the idea of having that awareness. And maybe it's not just words, maybe it's actions or the environment, but thinking about a better way to meet them where they're at and help them move forward. Yeah. And understanding that trauma impacted maybe the moment and what their behavior is. Yeah, Amy, I think that's such a great point of not putting your lens or my lens of trauma on an experience or their experience, and kind of projecting what we would imagine their experience to be, or their reaction, or how they're doing, or what their triggers are, but being really curious and patient and asking questions. And sometimes it's the questions that we can ask are not really about the trauma itself. We would ask questions about what's happening in the moment now. So I worked in a clinic where the exam room lights were very, very bright. And I would acknowledge them. And I would say, you know, these lights are really bright. How are you doing with this? What can we do to help with this? It was like over visually stimulation like that. So thinking about questions around, you know, typically I would do a full physical exam today. How does that sound to you? To start to understand what their experience is and where they're at with some of what we know can be triggering, but not always. Oh, I'm fine with physical exams. That's totally fine. It's the like women exams that are really hard for me. Okay, then when we get to that, I might be asking you some more questions about what you're comfortable with. Okay, that would be great. Ray, I'm wondering if you can say more about your comment, focusing on inclusion, not exclusion. What does that mean to you?
Good morning. I think it means to me that, you know, we never know what or who's going to walk through our doors here at the cafe. And so keeping everybody, you know, included in the mission and goals that we have here versus, you know, isolating them and excluding them from certain things, you know, and just trying to, you know, have the same kind of rapport with everybody across the board.
Yeah, you know, Ray, what it reminds me of is clients who really, really struggle when they come into a clinic and the waiting room is pretty busy, and they have a hard time tolerating being in that environment with so much stimulation. And instead of being like, well, I guess you just can't, this clinic is not the right place for you, saying, okay, how can we make this a more comfortable experience? So let's bring you into the exam room as soon as you get here. Or we might not have an exam room available, but can we bring you in my clinic, it was like a procedure room, which maybe wasn't that much better. There was a lot of procedure-y things, but you know, thinking about how do we meet them where they're at? Obviously, we can't like clear out the waiting room every time they come in. But I've even made suggestions around like, could they bring in some like headphones to wear, or, but start talking it through instead of making them feel bad about their reaction, you know? Does that resonate with you?
Yeah, completely. Yeah.
Yeah. Other comments or reactions to the comments in the chat? I love the comments. I love the dialogue. So this is Sam says definition of trauma-informed care. And I think you all did a beautiful job putting into your own words. And I think actually it's important to understand the tenets and what we're kind of trying to do with TIC. But I think also it's important to be able to digest it and be able to talk about it in your own words. And the more you can articulate what it is, the more you can actually apply it to your own behavior. And so I encourage you to sit around with your friends or call someone up on Zoom and say, hey, can I test out my definition of trauma-informed care on you? And talk with each other about how you articulate it, how you put it into your own words. These are the principles of trauma-informed care: safety, trustworthiness, transparency, collaboration, mutuality, empowerment, voice choice, cultural and historical gender issues, and peer support. I'm curious if we could just get a couple of kind of popcorn style shout outs or in the chat. Can you name one practice, policy, or procedure that would address something you do already, maybe in your practice setting, that addresses safety, either physical or emotional? And I don't know if I can see the chat. Doesn't look like Ken. So maybe, can you? Oh, yes, I can. There we go. So something you do already in your practice setting, or something we do in healthcare that embodies this idea, this principle of safety. So I'm gonna throw one out. When we have someone check in at a healthcare facility or setting, we often do that. We try to do it where they are giving their personal information and there are not other people around who can hear. So if you're in a line checking in, they usually have the next person in line stand a little bit farther back, right? And that's really to create some safety around disclosing personal information, even just your name, date of birth, and why you're there. So that would be like a practice that that's pretty standard in the healthcare system. However, it's not always perfect in certain settings. Yeah, protected health information. We're not going to share your information unless you give permission. Asking what makes them comfortable. Yeah, using a soft voice. I think what that part of that is volume is important and tone is also important in the safety piece. I think both of the Dora and Carrie's comments also speak to the trustworthiness and transparency, and let's move to that one. Anybody have ideas about things that we do in healthcare that build trustworthiness and transparency? Yeah, so Regina's talking about being able to pull a door shut or pull curtains closed for maybe to create safety, allowing for space. Yeah. Remembering when you're on the phone with someone to smile. Yeah, they can hear it in your voice. If it's appropriate, if the conversation makes sense that you would be smiling. Yeah. Inform before we treat. There's probably so many pieces to that, Cecilia. I'm curious if there was something you were thinking of specifically. But if it's kind of explaining a procedure or explaining a medication, or explaining how you might touch someone before you actually move forward. And then asking if they have any questions. That would be the transparency. How about collaboration and mutuality? What about that? What do we do? Does anyone use shared decision-making in their practice? I'd say that's probably a collaboration and mutuality. Asking what patients think about a treatment plan. You know, when you explain something and asking them, what do you think about that? How does that sound to you? Discharge planning. Yeah. Yeah. Yeah, staying in curiosity, asking the questions before you make a decision. Maybe being a little bit more curious. What about empowerment, voice, and choice? How do we give patients choice? What are things you do? Or what could you do? Or empower them to maybe make a decision or access care, elevate their voice. And while you're thinking about that, we can also kind of move on to the next one, because I'm curious about if anyone does anything implicit or explicit to address cultural, historical, or gender issues. Yeah, Cecilia, I like your comment. My idea of what they need may not be their choice at all, even if it means continuing to be marked, they have a voice and choice. Yeah, so really respecting their autonomy and their ability to choose, even if it's not the thing you would choose or the path you would choose. Asking the question, what do you want? Yeah. Doris says, I tell them what I want for them is not important and what they want is important and they have to share so we can move forward together. So really, I think that you're saying that's the mutuality, right? Is that you want to elevate what they want and you want that to be on equal ground or maybe not equal, but that what they want is more important than what it is you want for them. Yeah. Yeah, and so I think there is, you know, Dora's sharing her lived experience of her lived experience or her understanding or her empathy and compassion for patients who are coming from a different culture. And so I think that's important too. I'm curious about if people directly address cultural, historical, or gender issues in their patient care. If it's something that you acknowledge, you know, in your interactions with them.
Good morning again, it's Ray.
Hi, Ray.
I think that, you know, the biggest challenge for me with the gender issue thing is that, you know, it's relatively a new thing, this he, she, him, her thing. And, you know, I think that we have to give ourselves a break as much as them a break on, you know, not being so formal. And, it's okay to make a mistake. I'm sorry, I will work on it. It's okay to say those things because, they might have expectations, but, we don't know unless they tell us.
And I think what can be so powerful is when you thank them for correcting you, saying, thank you so much for correcting me. And you can say, you're sorry, you can say, I'm learning, you can acknowledge that you made a mistake and to thank them, because I think it's really hard for a lot of people to be correct people who are mistaking maybe their gender pronouns or their name, and just to say, thank you so much for correcting me. So yeah, to have some realize that we're not perfect. We are learning. We may be changing some very, very ingrained behavior ourselves.
Right. Well, and a simple, thank you for informing me. I will try and work on that.
Yeah.
It's just that simple.
Yeah. 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 I think asking people, making it standard of practice to ask people's pronouns when you are starting your relationship with them, and using introducing yourself and using your own pronouns and saying, I'm Joan, I use she, her pronouns, and yeah, saying, I'm just want to check in about your pronouns. And we started to get rid of the word preferred pronoun, because really it's not a preference, it's someone's identity. So we used to have that preferred pronouns in all of our language and paperwork, but I encourage you to kind of retire that word and just say your pronouns. Yeah. So we're going to move on for the sake of time. These are all great comments, and I appreciate people sharing kind of how they embody some of these principles. So I just wanted to bring us back to the slide I shared 2 weeks ago. Can you guys all see that? Give me a nod. Yeah. Okay. And so ask using these questions, those principles that's like a nice framework and it's all conceptual, but like, how do you embody that again, like in your day to day? And I think these questions just really speak to the principles, which is, does this cultivate a sense of safety? Am I and others showing respect? And does this build trust? And I think if you can ask these 3 questions and reflect, if the answer is no, then reflect on what needs to change. It could be something that's totally out of your control. And then when that happens, right, like, I'm going to go back to the busy lobby scenario, right? There's someone struggling with a mental health crisis in the lobby. There's a crying baby. And then you have a patient who's very sensitive to noise and stimuli. And I can't change the lobby environment. So like, what can I do? And sometimes all you can do is acknowledge the situation. So I used to work with a woman who the lobby was very stimulating for her, very overstimulating, and the check-in process was very activating for her to have. So when for whatever reason, long story, they had to ask her marital status and her household income for her to qualify for a discount. And she found that very activating, and they had to ask that quite frequently. And so I couldn't change that. I can't change that. That's what we have to do. But every time she came in, I would say, how are you doing? How was the check-in process? How did it go today? And I would acknowledge that it was usually very difficult for her. And we would spend a few minutes kind of regulating together and talking about how she was safe, and that those questions, you know, to talk through that. And eventually we actually came up with a solution that she would just write, they wouldn't have to ask those questions. She would just, she knew the questions and she would write down the answer and just slide a piece of paper to them. So we were able to be kind of creative. Now, Tina, I don't know if you wanted to say anything more about these questions or this slide.
I just want to name the distinction between the individual practices and, like you're referring to, sort of the collective or the organizational practices, and to continue to work within our sphere of influence, so that I'm, you know, in the chat and just in people's engagement, it's very clear that there is a spirit of being trauma informed as individuals. And yet, like you're describing, there are organizational systems and structures that may not be fully on board yet, and to, you know, address those as you can, advocate as you can, but continue to work in your sphere of influence through these series of questions. Yeah.
Thanks. Yeah, so I just kind of wanted to remind us about interpersonal neurobiology, and how when you think about our clients or patients coming in, they just want to, they want to have safety and belonging. That is kind of the number one social priority for humans, is safety and belonging. Probably number one is safety. Number two is belonging to your tribe, belonging to be accepted, so we can be taken care of and protected and have these social connections that we rely on. And so these are just, you know, some pictures of kind of these different kinds of groups and how important social belonging is. And that when you think about trauma, especially relational trauma or any kind of abuse or neglect, that really can disrupt how someone relates to relationships. And so when someone is coming in to a clinic or a cafe or a hospital, or you're coming into their home to do home health, you're thinking about, how does this person perceive a relationship? And relationships haven't always been safe. And so that's something that, you know, that's kind of using the trauma-informed lens around, how do you interact with this person knowing that that might be the case? Thoughts or reflections?
A reflection on what came up for me is this this distinction with some fluidity between external safety and internal safety. And so we can try our best to create conditions externally that embody safety, that have characteristics of safety. But even then, there may still be an internal sense of lack of safety. And so while we want to work at the external side, it doesn't always penetrate. And it can be true that somebody does not feel safe despite the conditions around them being and the people around them being quite trauma informed, which is not a reflection of, you know, you as an individual, as a clinician, as a peer supporter, whatever you're, as a nurse, a doctor, necessarily doing something wrong. That sense of internal safety is not entirely contingent upon the external conditions.
So I want to circle back to the behaviors that we kind of came up with at the very beginning that we find most challenging. And I'm wondering if we can use this trauma-informed lens to reframe that behavior. So this can be challenging, but I'm thinking about the one's situation that I'm trying to remember who put it in the chat about upon discharge, the patient was angry and yelling and name calling. And I'm curious if you could say more about that situation, and perhaps we could kind of use our trauma-informed lens around why that patient what might have been going on for that patient. We're never gonna know because we're not there and we're not in the patient's body and mind, but what could we make up about what about that particular situation that was so activating for that patient? What might have been activated? And I'm just looking in the chat. Who put that in there? Who's the key?
That was Regina.
Regina. I don't know, Regina, if you feel comfortable unmuting and speaking to that, or if you want to add some more context.
I think that the patient was known to have this type of behavior, but we didn't realize to the extent. It had been so extreme and not been recently visualized in our Samaritan system, although he had a block to be in our system that we found after he had already been in the system, in our care. So once he displayed, this was not displayed on admission. He was cooperative with admission and initial recovery in PACU, but it was as leaving, not having enough medication on board. Everybody around was stupid. How could the doctor do this to him? Quite a scene. We had a new, soon to be graduating nursing student who it inflicted trauma on her, seeing that, but very well able to see how we adjusted to it. The patient was isolated from other patients around. Intervention started initially with the initial nurse and just increased to other providers and also administration. Boundaries were set. And he was discharged, but we're all getting sued. We went, oh yeah, okay, no problem. I think his needs were met as far as physical. Can't really tell you what triggered. Do not know.
Yeah, and I don't know if we'll ever know, but I do have some thoughts around, it was something happened for him about being discharged, about leaving. And I don't know where he was going to, or if he had a place to go to, if that place was safe. But there was probably, I'm wondering if there was a shift in his behavior as he moved towards getting better and having to leave. And something about that. And also I was thinking about just, you tend to see this escalated big language, big voice, big behavior when people are feeling powerless. They've lost their ability to, their autonomy or their ability to make decisions, or even to be able to voice what they feel is right for them. And sometimes it sounds like he was feeling very threatened. But not in, by threatening back, I was thinking, thinking about his threat to sue and how, what does he have in his power? Why was he feeling so threatened? And I don't have the answer for why, but thinking about how threatening it might be, Tina's using the word abandonment. So thinking about what might be going on for him around being asked to leave or kicked out. And not that that's what we do in a hospital discharge, but it can feel like that to a patient, of being left behind or abandoned, and what his history is. Other people's thoughts about that particular case? So we have about 10 minutes left, and I wanted to present one case and see if we can kind of think through this together.
Could I actually ask you, I'm just, this case is just kind of, it's just reverberating in me, and probably because this is the behavior that is very activating for me as well. And so thinking about this through a trauma-informed lens, like we can step back, you know, zoom out as we do this kind of autopsy on it to say, yeah, he was probably, there was all of these things that were going on for him that were creating all of this activation, but this activation was showing up in a quite threatening, verbally threatening at least. I don't know how unsafe or, you know, if the word violent is too extreme, but how as caregivers, and what are the sort of strategies, I guess, that you would have as caregivers to be able to stay in the moment in a trauma-informed stance?
Yeah,
protecting.
I was thinking about that too. Having been in many of these situations, Ray, are you raising your hand? Yeah, do you wanna speak to that a little bit?
I just wanted to say, you know, sometimes we forget that we have to recognize our own self-awareness and how we're presenting the information. And sometimes, you know, if we, like, for example, are reading off of a script of something instead of, you know, recognizing our patient or our client on whether or not we are giving them too much information, and we need to slow down, you know, because that could really, you know, escalate that situation fastly. You know, our inflection, our tone, our own personal idiosyncrasies, things like that, you know, is really helps with situations like that.
Yeah. Yeah, and if you can intuit, or if you can take the time to reflect before you go into that interaction, that's ideal. If you're like, okay, how am I going to approach this? Like, typically I just go in and be like, all right, your discharge is around 3:30 and I have this paperwork for you, and let's just go over the medications, and do you have a pharmacy? Versus like, okay, this guy might need to like pull up a chair and sit down and say, hey, how was your night? You know, or whatever, and kind of like ease into it and be like, so I wanted to talk to you about next steps, and, you know, like kind of tailor that. I think what gets in the way of that is time. We have so much to do. And so I think that, you know, to Tina's point about sometimes our systems are not supportive of true trauma-informed interactions, because sometimes they take more time. Sometimes it takes, taking a walk around the unit with the person while you're talking with them, because it makes them anxious. They need to discharge that energy and they need to walk around. So, but go back to your, kind of point, Tina. I think sometimes the activation has happened already, and we're the people now kind of addressing and working with the person who's so activated. And I think some of the things we can do are knowing what your go-to grounding strategies are for yourself, and recognizing your own activation, to Ray, to your point, that self-awareness, and being like, holy crap, my lid is flipped. My frontal lobe is offline. My heart is racing. I'm getting a little sweaty, and I'm in this room with this guy. And okay, I'm going to take a big deep breath. I'm going to put my feet on the floor. I'm going to ground, and I'm going to take a moment. And I'm going to really tune into, how do I, you may not be able to stay regulated. This is very challenging work. And what I like to do is recognize my own activation and say, you are really activated right now. You're going to do the best you can, knowing that when we are activated, we're not thinking as clearly, we're not as sharp, it's harder to stay in that empathy place, but I'm going to do my best. And then I'm going to do all the things I know how to do to create a non-threatening environment. And I go back to that safety first, go back to the safety. And then I go to that like empowerment, voice, and choice place. So I look at, okay, am I standing? Is there a way I can crouch? As long as I'm not putting myself in physical danger, is there a way I can crouch down? Can I sit? Can I make myself smaller? Can I slow my voice down? Can I lower my voice? Can I also stay in that place of curiosity? And then I do a lot of reflection. You know, I'm going to call him Tom. Tom, you seem really angry right now. And I can understand that. This is a frustrating situation. This is really hard. This is really difficult. Even if I don't believe it is, he's clearly struggling with it. So I'm going to reflect his experience. That's his experience. I'm wondering if we could come up with a solution together. There might be some options here, you know, and it's I hope I'm going in the direction that you were thinking I was going to go, Tina, around just like, how do we acknowledge our own activation, stay as regulated as possible? And then I kind of want to fast forward just for the sake of time here. Let's say, you know, Tom leaves. Tom leaves, or we come to a place where he's a little more calmed down. He's maybe still kind of loud, but he's out the door. And now you've got the 6 people who are involved in that. What do you do with that? And I think a true trauma-informed organization would have a system for coming together and saying, that was significant. That was could have been a very activating event for our team, our group.
I'm preparing because at 9 o'clock I work with the nurse.
How is maybe you can mute Dora, Carmen. How is, sorry, I got distracted. How is everyone doing? You know, does anyone need a moment? How are you doing? Can you actually go into your next, whatever patient care interaction? Do you need 10 minutes? Do you need to take a walk around the block? And I don't necessarily think people need to disclose in that check-in what they need or how they need, but we need to teach people in our organizations how to do a self-assessment of what you need and how to say, hi, I don't know what I need. I'm really activated and I need that conversation, one-on-one conversation of like, okay, like how can we help each other as colleagues help regulate, and then check in about what maybe we can help identify what that person needs. And this, I think, is what's missing a lot in our organizations. We don't have these systems, and we don't teach people in our onboarding process how to do a self-assessment and that self-awareness around being activated, around what to do, what you need, what are your go-to grounding strategies, and then also how to check in with colleagues and identify when someone's activated and saying, hey, I'm noticing you're a little shaky after that. Want to just like run into the hallway for a second and chat and then say, how are you doing? Okay, you don't know how you're doing. Like, let's talk that through and basically help each other. So that was a lot. And I want to make sure we've talked about a few kind of activating situations, and I want to kind of invite us to maybe calm our nervous systems as we've thought through particularly this last situation, and invite Tina to read a poem that may help us kind of ground.
Thanks, Joan. This poem is not, it doesn't come under the title of trauma-informed care, but I think it captures it beautifully. It's entitled Compassion by Miller Williams. Have compassion for everyone you meet, even if they don't want it. What seems conceit, bad manners, or cynicism is always a sign of things no ears have heard, no eyes have seen. You do not know what wars are going on down there where the spirit meets the bone. And that includes yourself.
Thank you. And thanks to everyone who tuned in this morning. I hope that there was a pearl that you are taking away from today, something that you can implement in your practice or something you want to think more about. And if Carmen wants to say anything else about how to get your CME and all the things, go for it, Carmen.
Thank you, Joan. So yeah, again, we'll send you the instructions, the handouts, and the activity code via email today. Please be patient. I may send it in the afternoon. Please claim your certificate so you can complete the program evaluation, and that'll be really helpful to us. Remember, the activity code expires in 1 week. I'll email you the information about our YouTube channel. And this is the activity code. Write it down for your records. I'll make sure I send the activity code and the website to you. Thank you so much for your participation today. Thanks to our great speakers, and we'll see you in a couple of weeks, or maybe later today. We have You Are the Key to HPV Cancer Prevention dental version. So if you're interested, sign up for that one, and otherwise we'll see you in 2 weeks. Thank you so much.
Thank you.
Bye, everybody.